Thank you all for joining us today. We're very lucky. We're joined by Ms. Carla Wilbur, who will be presenting over the importance of the hospital care spectrum. I am recording the presentation today, and I believe the slides will be made available afterwards as well. If you haven't, we are a smaller group as usual. If you have any questions, thoughts, ideas, anything you want to share, please feel free. You can unmute your own line. If you want to put something in the chat, I'll be watching the chat as well. And with that said, Carla, I will turn it over to you.
Thank you so much. And I'm very happy to be with you guys today to talk a little bit about the care spectrum. So what we'll go over is what is a clinical care delivery spectrum, and we call it care spectrum for short, why it's important to you, some potential barriers and factors of success, and then the key steps in developing a care spectrum, and give you some examples and early results. We've done this work with a number of hospitals now throughout the country, and have seen some things that have really been very beneficial for this process. So what is the clinical care delivery spectrum? This is a way for you to formally define who can be cared for at your facility. So that has to do with diagnoses, clinical indications, and that would be acute and observation. Now, we have used the process of defining a care spectrum for swing bed as well. Some hospitals have gone through this process with their swing bed patients to understand what type of patients that they can care for. So it's, the process itself can be used in any of the different areas. But basically what we'll talk about right now and today is the acute and observation. So in doing this, you also determine who really cannot be appropriately cared for at your facility. You look at staff competencies, providers availability, all of the different services that you may use for a different variety of patients. And those are the things that really dictate the type of patients that you can care for. So what do you have available? What do you not have available? And what does that look like with your population of patients? So we've seen that, most of the hospitals have not gone through a real formal process of looking at what kind of patients can be cared for. Sometimes there's a very loosey-goosey type admission criteria, but nothing formal to develop their care spectrum. One of the first things that we advise and think that needs to be done is just to look at your patient population in your service area. Understanding, what type of services are coming to your area. What does that look like as far as volumes? What does that look like for your market share? And then all of your payers as well. So a good market analysis is a great place to start. Why is this important? We've seen a decline in our acute care admissions over the last several years. There have been trends of rural hospital closures, and that's really important. We want to keep patients in our communities and in our hospitals instead of sending them to other places for care. It's pretty well known that if we lose patients to transfers to other organizations, that we might lose them altogether, and they won't be using the services at our organization from there on. The hospitals that are in a cost-based reimbursement structure have to have volume due to their payment system. And then it also has to do a lot with staffing, recruitment, hiring, and retention. All of those are also challenges as far as national trends. The care spectrum improves procedures and workflows. It helps it to have greater efficiencies within the admission process because there again is not that variability. There's not a long process that goes back and forth. What we hear a lot from the ED provider to the hospitalist or private doc, going back and forth trying to determine who can and who cannot be cared for. So that decreases our variability in the clinical decision-making, known to increase our patient satisfaction because they're not sent away from their community. They can receive their care at home, and they can also have their family close by. Family doesn't have to be burdened with that transportation possibly. It's also been known that to improve our staff satisfaction. Very early on in this work, when we were helping hospitals with their care spectrums, we heard that it was important for keeping the younger staff that had just come out of school and they came into the hospital and realized, oh, well, we don't keep very high acuity patients. Now, there are high acuity patients that aren't appropriate, but there are some that we can keep, and it satisfies the staff. We build our volume. We have cases that staff are happy with, and then they don't have to be called off because our volume's low. So that has a potential positive impact on our revenue as well. This is just a map that we create based on data that we find and to show the rural closures. So the last time we ran the map, it was in June the 28th. And at that point, since 2010, there have been 138 rural hospital closures. And that's not good. We don't want our hospitals closing in our rural areas because that leaves our communities without care. The variation in ED admission rates is really interesting too. And this map shows where the patients in different places, different geographical locations, where admissions from ED are higher and lower. It's just kind of interesting to see that there is a great deal of variation among ED admission rates as well. This one is specific to the ED admissions in Oklahoma. So as you can see from the critical access all the way up through the short-term acute care hospitals, what the ED admission rates are. So within your care spectrum, we want to look at key metrics. So we look at the patient throughput. That has to do with timeliness in the ED. The care spectrum definitely impacts that. It impacts the inpatient admission process. We want to target about 10% of our ED visits for admissions to our facility. Now, that is variable based on the services that you offer, but that's the target that we like to have hospitals use. We want to decrease our transfers. You need to collect data on your transfers, transfer diagnosis, provider, location. We want to target less than 6% of our ED visits being transfers. It also impacts streamlined processes. So system inefficiencies can be identified when you go through this process. And you can incorporate telehealth. We've had several hospitals that have developed their care spectrum, and they realized that if they added telehealth in this certain area, that they were able to keep some of their patients in-house instead of transferring them out. Reducing cost and improving value. Appropriate patient care services are delivered, and they're provided in the most appropriate care setting. This just shows you incremental volume analysis. So if you look at the top box, it shows that the average daily census acute, which included observation, was 8.2. And at the bottom, just growing the average daily census, including your observation of 2 to a 10.2, and what that has to do with your net margin. It's just a visual financial impact really kind of helps people understand that just growing a little can definitely help our bottom line. And that's another reason we want to keep patients in our hospitals. So one of the questions that you have to ask yourself is this the way we've always done it? Do we have that mentality? If that's the case, then we need to start looking, as everybody says, outside the box. We need to understand our barriers. Are we making the decision to transfer with the goal of maintaining optimal health of the patient, or are we reacting to it? Do we hear the what ifs a lot in our organization? We need to ask the question, what happens 80% of the time? So we hear a lot from hospitals that their providers are ask the question, well, what if that happens? Then we have to transfer. Are we really sure we should keep this patient? So we need to really look at what happens most of the time. If comfort care is needed, why are we transferring patients? We've also found through this process that many hospitals would transfer out a patient that it's obvious that that patient just needs comfort care. So why don't we keep them there instead of transferring them out? Are we missing opportunities for observation patients versus transfer? There was a hospital that we worked with, I believe it was in Arizona, and the medical director of the hospital told us that he used to be the medical director at a tertiary center that received the transfers from the hospital that he was at now. And he noticed that the hospital was sending a lot of patients that all they did was just watch them, observe them, and then they went home. So when he became the medical director at the smaller rural hospital, he said, no, we're not transferring out until we really look at that case. Because a lot of the patients that you transferred to me when I was at the big center ended up going home anyway. They were just observation patients, and then we sent them home. So we may be missing opportunities there. Are we missing opportunities for observation versus discharge home? We've seen a lot of hospitals that have an enormous length of stay in their emergency department, and then those patients are discharged home. Well, if we're going to treat and evaluate and treat and evaluate and treat and evaluate, those patients may be the patients that need to come in for observation instead of discharging home. And then there are a lot of components to consider: your EMS, medical staff relationships, communication, equipment, staffing, and then again, your clinical competencies. So to develop your care delivery spectrum, you really need a team. So you need to involve, of course, nursing, your pharmacy services, your providers. They are very key because we need provider buy-in. EMS, consulting specialty services, if you have those. We need someone that represents all of our supplies and equipment so that when we're going through the process of really analyzing what patients can be cared for, we need to know that we have the appropriate supplies and equipment that we need. And then case management and UR. So in an interdisciplinary team, nursing, of course, under nursing, we want to evaluate our competencies, different certifications, what might be needed. We really want to understand from nursing the comfort level. So when we're looking at different patients transfers and different types of patients that we do typically send out, is this a comfort level? Is it possibly something that if we had some education, we would be able to keep those patients? Is it staffing? Do we have our staffing ratios set appropriately? What are our shifts look like? Right now, staffing has been a struggle for everyone across the country with the huge staffing shortage. So that may impact your ability to take care of a certain type of patient. And then what is our leadership structure? How does that all work? So nursing has a lot to do with helping to identify the kind of patients as well. Case management. We want to make sure that the patients that we do bring in, we clarify that medical necessity. So do they need to come in as observation or admission? So we definitely need case management involvement in that as well. We need to really make sure that we all understand the difference between acute admission and observation stay. And then making sure that we all have we use either interqual or MCG care guidelines if you don't already have those in place to help us through this process. Observation as a level of care, there are many different definitions, but I've included here the most widely used CMS definition, specifically around the understanding of if this is a short-term treatment of assessment and reassessment, as I described, those patients with there's a long length of stay in the ED, is that what we're really doing there? Instead of moving those patients to an observation status within our unit, instead of leaving them in our emergency department. So the providers are going to participate with us in this process to help inventory the type of services offered, what on-site availability we have, and do we have opportunities to expand access. One of the hospitals that we worked with recently in upstate New York that went through the care spectrum process realized that they have access to stress testing for cardiology. They have a cardiology clinic next door to them, but they really had never had a good relationship, never tried to build that relationship. Therefore, they were sending all of their cardiac rule out patients, chest pain rule out patients. They were sending all of those out. They didn't even have the stress test schedule of that cardiologist. So they were able to, they saw that they transferred a great number of cardiac patients out, and they were able to build a relationship with that clinic and had the ability to then bring the chest pain rollouts in instead of transferring them out and have them receive stress tests the next morning or however that was scheduled. But they were able to do that because they realized through this process, they had many of those patients that were leaving. The providers help with what type of patients do the inpatient and ED providers believe are appropriate. So we have to have both the inpatient and the ED providers discuss this, who they believe is appropriate for acute or obs. Do we have any concerns regarding medical necessity determination? That's why we want to work with case management on that. And then do the providers have any concerns regarding competencies of our clinical staff? And if that's the case, then maybe we need to have additional education or training. What type of consultancy services do we have available? Do the inpatient and ED providers feel that as they're evaluating these transfers, well, we could have kept this patient if I'd been able to consult with someone. We need to know that because there may be a possibility that we can add those consultancy providers through telehealth, or is it just someone that they need a relationship with that they feel like they can count on to ask questions about certain types of cases? Are there variable hours of availability with our consultant services? Are we currently using, and what can we not provide? And again, is there any opportunity to expand telehealth? And if we're in a network, are we really leveraging our network resources and potential opportunities that they have there? Supplies and equipment is really important. We don't want to start bringing in patients that we don't have the right equipment and the right supplies for. When we evaluate transfers out of our organization, are we seeing patients that we've transferred out because we don't have certain supplies or certain equipment? So we want to look at all of our equipment, evaluate the age of the equipment, condition. Do we have enough of it? Do we have access in a timely manner to certain things, such as maybe bariatric beds? Do we house bariatric beds? I have one hospital that I've worked with that is actually in Hawaii, and they're on an island, and their facility is older. They don't have a lot of storage, and they had started turning away patients that needed bariatric beds because they had no bariatric beds. So they started looking at how can they keep a bariatric bed somewhere in the hospital so that they could accept the patients that they're having to turn away or transfer. So it's really important that we do a deep dive into our supplies and equipment. So when you're looking at the transfers, if there was some reason that we transferred because of that, then you'll know maybe that's something we need to look at that we add in our organization. And then pharmacy, we want to make sure that our pharmacy is involved. Do we have a robust formulary? Are there a lot of things missing that we can't keep on hand because we don't see that type of patient a lot? Is it possible to have access to get the drugs that we would need? Do we have a relationship with another system by which we could order? How long does it take? Do we have after hours pharmacy resources available as well? So the key steps in your development of the care delivery spectrum is to gather and review all of your pertinent clinical and utilization data. What type of patients are you currently bringing in? And what type of patients are you typically not bringing into the organization? And then conduct a gap analysis. You need to conduct interviews with key stakeholders. So that means understanding what the nursing staff say, what all of the providers say about the patients and the type of patients that you can care for there. Sometimes you'll find in just having the one-on-one interviews that there is a different perception of what patients can be kept in the organization. And so we definitely want to have those one-on-ones to understand what everybody believes is happening. Then as a team, audit your top 5 to 10 reasons for transfers. So go back about 6 months maybe and say, what were the top 5 to 10 reasons for transfers? And as a team, look at those transfers to determine, could this patient have possibly stayed at our organization? No one is second guessing the providers, but it's just a method of, as a team, looking at the transfers and trying to iron out any of the preconceived notions of we couldn't keep the patient here. You'll find that there are those that are absolutely, they do not need to stay. And then there are those that are in that gray area. So we know that, yes, we can keep this type of patient. And we know that absolutely no, we can't keep this type of patient. But what about those that are in the middle? So then you'll craft your care spectrum based on those yes, maybe, and no categories. And understanding that the maybes, maybe that's an area in which we need that education, or we need that new piece of equipment, or we need, we need to have consultancy services available on that particular type of patient. Those are the ones that you really want to do a deeper dive into. We have worked with hospitals and done this before, and then helped hospitals to start their development of care spectrums. And what they typically find is there are lack of specialty services available. Some hospitals have not used or have even pursued telehealth services, and that could have helped them to keep more patients in their hospital. Not having 24/7 respiratory service. One of my hospitals that I worked with did not have 24/7 respiratory service, but they had them on call after hours. But what they did, because they were turning away a lot of respiratory type patients after hours, The respiratory therapist did some more one-on-one education with the nursing services so that they felt more comfortable with that type of patient. Nursing pushback, again, provider pushback. So that's why we want everybody at the table so that we don't have variation. They found that there was education needed. EMS bypassing. So you may not know of this because you wouldn't see them as in your ED because EMS was bypassing. But one of the things that it really helps to have a formalized care spectrum is then you can have that conversation with EMS about the type of patients you can care for. And that way they don't bypass your hospital thinking that you can't deliver that service. ED and hospitalist variability, of course, we found a lot, and then staffing. This is just an example of one of the hospitals, and this hospital is in Pennsylvania, and they reviewed some ED charts that went from January 19 to January 2020. And the information there, the average patient age, ESI level, their top discharge diagnosis was chest pain was their reason for being transferred, lack of telemetry or provider or clinical staff competence. So 50% of the transfers had a primary specialist available. They identified 10 potentially avoidable transfers. That was 45% of their charts reviewed could have potentially stayed there and been a possible admission. This is just an example of one of the draft care spectrums that one of the hospitals that we've worked with put together. And they went through their top 10 transfers, the diagnoses, the evidence-based guidelines that they were using, because everyone should be using evidence-based guidelines. And then they categorized their top transfers into minimum, low, and moderate, and high categories, so that they could then use this and say, for these low category, the low risk categories, this looks like something that we might be able to keep. So they wanted to kind of craft theirs in the risk categories. That's just an example of one. And then this is an example of another one that one of the hospitals put together for these 4 different categories of chest pain, CHF, AFib, and syncope. And then if these were low risk, intermediate risk cases, they just kind of outlined theirs so that they had an idea of what they could do, either to observe, admit, or transfer or discharge home. So of the one that I just showed you, they went through their process, and their admission rate had varied from a low of 2.8 to a high of 5.3. Their primary goal for going through the process was to determine the root causes of the decline in admissions. They did an internal review of their ED transfers, and they definitely revealed that inconsistent approach to transferring because they didn't have a standardized process. So they began to see, after they developed their care delivery spectrum, they began to see an increase in their admissions for chest pain, COPD, pneumonia, and syncope. They had cardiology and respiratory therapy collaborated and developed that they were part of developing the care spectrum. All of those patients previously had been transferred to the higher level of care, so they were able to retain patients. And they saw a 10% increase in their ED admission rate compared to the prior year. So that was really good for them. The other one that I had mentioned earlier, they did make significant strides in reducing transfers. by a 45% decrease in their ED transfers, and their ED visits have increased. So they have a average daily census now. They were having a problem with keeping an average daily census of 2, which is required. So they've seen a really nice increase there by adding the telehospitalist program. They added full-time echo tech coverage. And then they replaced a nuclear camera, which they had found with their transfers that these were some of the reasons that their patients had to be transferred out. So I'll stop there. If you all have any questions, I'd like to take some questions about the process of developing your care spectrum. If there are any, or comments.
Would anyone like to share what you've done in your facility along these lines or changes that you've made?
Or have you gone through the process? I'd be really interested to hear if you've gone through the process before, or what you are using as kind of a guide for admissions versus transfers. They are a very quiet group.
They are. It is lunchtime, but Carla, we really do appreciate your time and everything you shared with us today. And so I know it was a lot of really great information. If you guys have any questions after you get off the call today, please feel free to reach out to me and we can get in touch with Carla.
Absolutely.
Yeah. And so with that said, if there are no last minute questions, everyone have a great day. And thank you, Carla.
Oh, absolutely. Thank you. Bye-bye.